Welcome to Grand Rounds. My name is Adit Talati. I'm one of the Grand Round directors, along with Drs. Alex Harris and Rebecca Muley. Next week's Grand Rounds is going to be our annual Brickell Grand Rounds. Our awardee is Dr. Jeff Bridge, Director of the Center for Suicide Prevention and Research at Nationwide Children's Hospital. The title of his talk is A Call to Action in Primary Care Settings, Youth Suicide Prevention. We encourage you to come downstairs louder. We encourage you to come to the auditorium because this is an in-person and an award talk. Today we have a special Grand Rounds. Please signal if I become inaudible. Today we have a special Grand Rounds that's part of our early stage investigator series where we spotlight the work of 3 of our junior faculty. In the past, the 3 talks have typically been unrelated, but today they're connected by a common theme: understanding, implementing, and reducing the impact of various forms of violence and its sequelae. It's also apt that this Grand Round is scheduled today because this month is Domestic Violence Awareness Month. I will try and spend as little time introducing the speakers so that we could get on with the show and give them as much time to speak. Each speaker will speak for about 15 minutes, and I'm sitting there if you exceed those 15 minutes to give you dirty evils. And I will introduce each speaker in turn, and then we'll have a common Q&A at the end. If you're participating by Zoom, you could answer or ask questions at any time during the talk. You don't have to wait till the end, but given the nature of the talk, please specify which speaker you're asking the question for, okay? We'll start with our first speaker, and I'll introduce each one before the talk. Our first speaker is Dr. Stephanie Rolin. She is a forensic psychiatrist and researcher. She graduated from Dartmouth with an MD and an MPH and completed her residency in psychiatry, as well as her fellowship in forensic psychiatry here at Columbia University. She's passionate about addressing health equities with a focus on the public health crisis of mass incarceration of people with mental illnesses. She is mentored by Dr. Paul Applebaum and Lisa Dixon and is developing and testing interventions to reduce the risk of violence for people with psychosis. Her research has won multiple awards, and she's been supported by grants from the NIH and the New York State Office of Mental Health. It's an absolute pleasure to welcome you today. So let's give her a warm applause.
All right. Is that okay on the volume? Perfect. Hi, so I'm Stephanie, and I'm going to be talking today about violent behavior among young adults with early psychosis. To start, so as said during the introduction, I am a forensic psychiatrist and a physician scientist, co-mentored by Paul Applebaum and Lisa Dixon, as well as a larger team of people here, and I have no disclosures to report. The objectives of my talk are to understand how violence risk changes during the course of psychosis, talk about some risk factors, and learn about preventative strategies to help reduce violence. Before I get started, I want to talk about On Track New York for people who may not be familiar. On Track to New York is the Early Intervention Services, or EIS, model for New York State. This is our wraparound care for young adults who are developing early psychosis, typically people who are 16 to 30 and within 2 years of onset of psychosis. On Track New York has a lot of different components, including case management, psychotherapy, supported education and employment services. And what's really great about models like On Track New York is that they've been shown to improve outcomes for adults with psychosis, and that people who are engaged in EIS care tend to have fewer hospitalizations, fewer symptoms, and higher quality of life. On Track New York has, I think, nearly 30 locations throughout New York State, and my work is based out of that network. So to start with, although the absolute risk of violence is small, individuals with serious mental illnesses have an increased relative risk of engaging in violence compared to the general population. And that relative risk of violence is 3 to 4 times that of the general population. And my focus is on early psychosis because violence is highest earlier in the course of psychosis, and then it decreases over time. And so that's why I focus at that point where violence seems to peak. Whenever I talk about violence during early psychosis, I always take a moment to address mass shootings because it's something that is often on people's minds. Mass shootings are something that happen in America. It's something that we read about almost every day. Although overall, mass shootings only account for a small fraction of murders. It's a lot of the stories, but a small fraction of murders. And my colleagues here have done an analysis of over 1,300 mass murders between 1900 and 2019 and found that nearly 90% of those perpetrators had no lifetime history of any psychosis. And in fact, in the United States, mass shooters are more likely to have some type of legal history, to use recreational drugs or misuse alcohol, or to have a history of these non-psychotic psychiatric or neurologic symptoms. So although this is a type of violence that exists, it's not closely tied to psychosis and is not the type of violence that I focus on in my work. So what kind of violence do I focus on? The violence that I focus on, it might not be something that you read in the headlines, but it's something that our patients may be experiencing at home. They may be repeated conflicts with people in the home, maybe pushing, shoving, throwing things at a family member. And over time, those types of violent episodes do take a toll on the patient, their family, and the community. So what we know from research is that 1/3 to 2/3 of caregivers to individuals with psychosis report at least one incident of physical violence or aggression within the past year. And that for caregivers who experience violence within that caregiving relationship, they do have worse mental health and they have resentment and hostility towards the person that they're taking care of. Another challenge for families is that if a caregiver calls 911 for assistance because they need help, the reality is that person with mental illness is at increased risk of being killed by police in their own home, even if not armed. And so families are very much experiencing this at home and feeling afraid to ask for help, afraid to call for help. And that this type of violence contributes to intergenerational trauma, where we really see it taking an impact on people over time. So what can we do about violence? I've become interested in thinking about behavioral interventions reducing violence. And there's some really good research showing that CBT-based behavioral interventions have efficacy in reducing violence in a number of different settings and populations, including for adults who have histories of intimate partner violence, for veterans who may have a substance use disorder, and for juvenile offenders. There have been small studies looking at CBT-based interventions to reduce violence for people with psychosis, and so far they've been very promising. And one of these was done by Dr. Haddock and her team in the UK, where they compared a CBT intervention called Picasso. This was a CBT that was targeting violence, anger, and psychosis, and they compared it to a control condition. And what they found was that over the 1-year follow-up, people who had received the Picasso intervention had less physical aggression than people who had not. So the focus of my research is to take this existing model of CBT, the Picasso intervention, and adapt it to On Track New York. One of the challenges with the trials that have been done of CBT-based interventions to reduce violence for people with psychosis is that they have been mostly done in forensics hospitals. So these are for people who have engaged in some type of serious crime and have been sent to a forensics hospital, typically for very long stays. That's a very different population than an outpatient population. So there's some amount of adaptation that needs to happen. And then after the adaptation, to conduct a pilot trial evaluating the feasibility and acceptability. So I started by interviewing people who are at EIS teams. So I interviewed EIS team members. I spoke to clinicians and peer specialists about their experiences treating patients who had violence. And then I also spoke to EIS participants, to the patients themselves, specifically speaking to people who had recent violent ideation or behavior. And overall, I got really positive feedback from all groups on the intervention. People said that there was a need to talk about violence in treatment and to do so in a structured way, though clinicians emphasized that there needs to be staff training and flexibility in implementing a model like this. So in speaking with the EIS participants, the patients who have had recent violence, I used the theory of planned behavior in order to see whether this type of Picasso intervention is something that they might want to engage in. And what the theory of planned behavior is, it's a theory that looks at how might people make a behavior change. And so it starts by saying there are 3 constructs, which is the attitude towards the behavior, the subjective norms, and then perceived behavioral control, and that those influence a person's behavioral intent to make a behavior change, and then that affects the behavior. So in these interviews with people, the behavior that I'm interested in is reducing violent behavior, and that has to be preceded by an intention to reduce violent behavior. And then I asked about each of these constructs so I can understand. And overall, people had negative attitudes towards the behavior. People recognized their violent behavior and really wanted to make a change about it. And one of the representative quotes here, this is from a participant I was speaking to. He said, when I told my team about the violence that had happened, I just started crying. I was feeling angry at myself. And I have all of this anger. It's just pent up. And then for subjective norms, overall subjective norms were also very positive, supporting the need for change. People felt that, especially their parents would want them to engage in something like this. With one person telling me, my mom placed me into counseling and she would like me to continue anything having to do with it. And then perceived behavioral control, people really felt like they needed more support around the behavior changes, with one person saying, controlling anger will allow me to resolve certain issues before I start fights or get into fights. So people were recognizing that there was skill building that they wanted to work on. So more from these interviews is that teams, so these are the clinicians and peer specialists that I spoke with, they saw violence as a really important issue to address. They noted that the patients that they were working with were having real consequences, including being incarcerated, losing work or school opportunities, getting disconnected from teams, and homelessness was a theme that came up over and over. And they also noted how much distress it was causing the patient, their family, the team, and that even though it was a minority of participants, it was really causing distress that everybody was feeling. So I'm going to share some quotes from these interviews. So here I'm asking about a person who had a recent violent episode, and I'm asking, did this impact the person's life in any way? And the team member tells me, I think the experience was something that was really scary to think about. And also he was just like, that's not who I am as a person. It's sad that I could think that way or want to do something like that. So this person in their recovery was really, this patient that they were working with in their recovery, they were really struggling to understand what had happened and to resolve that in their idea of who they are as a person. Here I'm talking about a violent episode that they had told me about. It had just happened a few days ago. And I asked if there was any impact on the person's life from this. And the team member tells me that the participant was evicted. It did affect them in that aspect. And now we're trying to help them get housing or get into a community setting. I asked, so this individual is currently homeless? And they say, yes. Unfortunately, his mom had kicked him out. They had referred him to a shelter, but he didn't go. He's not taking care of his hygiene. He tried to go back home and he wasn't allowed in. So he's basically homeless right now. So this was a young person who was newly homeless, living at a fast food restaurant down the street from the clinic, and they would go every day to check in on him, buy him breakfast, but were really feeling overwhelmed with what options they could connect him with. In speaking to participants, the patients themselves, for their perspective on violence, they really told me that they were experiencing distress, shame, and guilt over the behaviors, over what had happened, and that it was really hard to talk to their team about violence. And so I'll share some quotes from the interviews with them as well. So here a participant is sharing their experience where they were sitting down, watching TV, they start hearing voices, they're talking about people's looks, they start saying people are ugly. Now I'm trying to say the opposite of them, and they start throwing a temper tantrum, and that's what triggered my anger. I started to rampage around the house, and my mom was scared. I say, that sounds really upsetting. And the participant says, I wish I wasn't even alive. I don't deserve this. So just how heavy those behaviors were for him. And I do want to say that I'm based out of On Track, New York. So people are connected to this wraparound treatment team. And when someone tells me something like this, I wish I wasn't even alive, I make sure that they're connected to the services they need. And his team was aware of this and working and creating a plan for him around this. So this wasn't new, but I always make sure that people have the resources and support they need. Another participant I was talking to, I asked, are there ways in which your team asks you about violence, talks to you about violence that you think is more or less helpful? And the participant said to me, in the moment, it has to be very specific with the words that you use, and you make it useless or purposeful. And this is something that's come up quite a few times because I study violence, and violence is a big word. It's a heavy word. It makes us feel things. And sometimes could we use another term? Could we do that? But what participants have said to me consistently is that they need this to be clear. And as hard as it is to say violence, this is something they're experiencing in their life. And that if a clinician is clear and direct in asking them about it, they have an easier time understanding it, as opposed to if we use vague language or terms that may mean other things. So after using all these interviews, I adapted the model of CBT Picasso. I've got my manual, we're ready to go. And I'm now conducting a pilot trial evaluating the feasibility and acceptability of this intervention. So right now I'm recruiting dyads of clinicians and participants. So I'm recruiting clinicians who are employed in the clinics. I'm training them in this intervention. And then I am recruiting an existing patient of theirs. So far I have recruited and trained 6 clinicians, and I have 2 patient participants that have been consented, and they're in the midst of completing this intervention. The early feedback has been really positive. Clinicians really like the manual. They like the manual so much that they've asked me to make a patient version of the manual where patients can have their own manual that they're working with. So that's something that we're actively developing and testing right now. And from the participants, they have had really positive early feedback, feeling that the intervention is helping them recognize the progress that they're making and building on it moving forward. And so results of that are still to be determined. This is actively ongoing, but I'll be excited to share that when it happens. Just want to take a moment to thank my large team and number of people here who have been helping me. I've also been funded by the NIMH loan repayment program. So I want to take a moment to talk about that. So the NIH has a loan repayment program, an LRP award, which is a grant that pays up to $50,000 of student loans per year for people with student loans. And in exchange, they ask for people to be 50% research. And not only does this help people with their student loans, an NIH study of people who are funded through the LRP demonstrate that there's a double increase in productivity for people. And that's maintained up to 15 years afterwards. And so something that I've been actively involved here with at Columbia is creating an LRP preparedness program, which is a virtual seminar that really supports people through the application to the LRP. So a lot of early career faculty throughout Columbia have been doing this LRP program and applying. And I wanted to take a moment to shout it out because prior to 2019, there were no specific LRP resources at Columbia. We have a lot of resources to help researchers, but the loan repayment program is really targeting the earliest stage researchers because right now student debt just for medical school is over $200,000. And that doesn't include undergraduate loans or other graduate style loans. And that these loans are disproportionately affecting students who are minorities and first generation. And so in my seminar, I will say virtually all of the seminar participants are underrepresented in science, according to the NIH definitions. We've had more than 30 people at this point go through the program. And I will say 75% are women, 50% are Black, 40% are first generation. So this is a group that is very diverse and has a lot of need, a lot of student loans. And most of the people have no prior NIH grant writing experience, and everyone says they don't really know what the objectives are of the LRP when they start, but they do by the end of the seminar. And we've had some great outcomes. So 10 of the 11 applicants were funded in 2022, 12 of 15 were funded in 2023, and it's been really all across the NIH different centers. So if you're an early career researcher, student loans, send me an email. I'm always happy to help. Thank you.
Thanks so much, Dr. Rolin, for sharing your work and all your efforts to help others in the department through the LRP program. We'll do question and answers at the end for those joining late. Our next speaker is Dr. Corianna Sichel, who is also a member of our department. Dr. Sichel completed her undergraduate studies at Duke and received her PhD in clinical counseling psychology from NYU. She's completed her postdoctoral training in the Center for Behavioral Health and Youth Justice at Columbia under the mentorship of our Dr. Kate Elkington. Are you here, Kate? As of October 1st, she's going to be a tenure track assistant professor of behavioral sciences in emergency medicine, but we have been assured that she's going to keep her collaborations and have a joint appointment with us here. So she's not leaving fully. Corianna has particular interest in the dissemination and sustainment of evidence-based practices, as well as research that addresses and prevents behavioral health problems in youth. Much of her work and training has focused on understanding and addressing the needs of youth involved in the juvenile justice system. Her research has been supported by an NIMH K23 Career Development Award. She also serves as the Associate Director for Clinical Research in the Center of Behavioral Health and Youth Justice, and is a co-I on several other NIH-funded grants. So I'm super excited to welcome her.
Hi, can you hear me? Okay, great. So just got set up. Okay, so today I'm going to be speaking with you about identifying and addressing post-traumatic stress and barriers to care for youth involved in the justice system. Thank you for that introduction. It covered a lot of the information on this slide, but just to kind of highlight one point that wasn't covered, I had the really lovely, have had the really lovely privilege of being a part of 2 NIMH R25 fellowships. First, the CHIPS program in 2022, and currently the Implementation Research Institute, or IRI. And I am happy to speak with any early stage investigators who might be interested about either of those experiences. And I have no disclosures. Here are our learning objectives. Before I get started and into the presentation, I wanted to give a couple of notes. First, I'm going to be speaking with you today about really horrible things happening to young people. And I know that I myself find this topic to be very heavy. So I want to encourage you as an audience to do what you need to take care of yourselves. The second note that I want to give is about language. You will hear me talk about the criminal legal rather than the criminal justice system. And this is in recognition that much about this system is unjust. However, you'll also hear me talk about the juvenile justice system. And this is because the criminal legal system tends to deal, not always, but usually with adults, so people who are 18 or older, while the juvenile justice system focuses on people who are younger, so up to age 18. And I've been told by lawyers that there is no such thing as a juvenile criminal legal system. Moreover, a lot of the work that we do within the Center for Behavioral Health and Youth Justice is with people and systems that are part of the juvenile justice system. And as clinicians in the audience will appreciate, when you're working with people and trying to build collaborations, it's really important to use the language that they use to refer to themselves. So you'll hear me use both terms in this talk. This data was drawn from a recent report actually published this month by the Office of Juvenile Justice and Delinquency Prevention. And there are a couple of things that I'd like to draw your attention to. First, you can see here that the majority of youth who are involved in the juvenile justice system are actually on probation. This means that they're residing in the community with their caregivers. And this is a really important point because we know that, like other youth involved in the juvenile justice system have better outcomes when they are connected to and able to be supported by their families and communities. While families and communities can constitute contexts of risk for youth, they can also be tremendous sources of protection and resilience. And I'll pick this up later in my talk when we get to my K23. I also want to note that the data that I'll be presenting on today were exclusively drawn from young people who were not detained or incarcerated at the time of data collection. I also want to draw your attention to some disproportionalities. So we know that nationally, 51% of youth are assigned male at birth, but here we see that 72% of youth in the juvenile justice system are male. Nationally, 15% of youth are Black, but we have an overrepresentation of minoritized youth, particularly Black youth, in the juvenile justice system. And as you can see here, 37% of youth in the juvenile justice system are Black, and that's actually up from 33% in 2005. Youth involved in the juvenile justice system are more than 4 times as likely to have behavioral health disorders and more than 10 times as likely to report trauma compared to their counterparts in the community. And these youth are also over 80% of them, over 80% of these youth who are involved in the juvenile justice system report exposure to at least one traumatic event. So generally, when we think about these young people, it's not have they had traumatic experiences, it's how often and what kind. In order to begin to understand the patterns of traumatic experiences and the problems that these experiences can cause for young people involved in the juvenile justice and criminal legal systems, colleagues and I used a sample of 316 court-involved young adults aged 18 to 24, drawn from a larger study here in New York City. Our sample was 75% male and 67% Black. And when we think of the vast array of awful traumatic things that can happen to young people, one way to begin to categorize them is using these three different typologies. So let's see if my pointer works. Yes. So we have interpersonal traumatic experiences, non-interpersonal traumatic experiences, and then experiences of separation and loss. These items are actually drawn from a measure called the LIGHT, or Lifetime Incidence of Traumatic Events. And you can see here that interpersonal traumatic experiences involve violence between at least two people, while non-interpersonal experiences are things like natural disasters, and separation and loss usually, but not always, involves the death of a loved one. In our sample, the three most commonly reported traumatic experiences were having someone in the family die, having someone in the family in the hospital hurt or sick, or seeing someone else get hurt. When we think of traumatic experiences, we want to think not only of the type of traumatic experiences, and I should mention here actually that interpersonal traumatic experiences are frequently but not always associated with worse prognosis for young people. But another aspect that we think of when we're thinking about the potential impact of traumatic experiences is the age that that experience occurred. And previous literature suggests that there's kind of a sensitive period. So when youth experience traumatic experiences before the age of about 10, they tend to have worse outcomes. And in our sample, we saw that the average age of first traumatic experience was 6. Finally, when we think about trauma, we also think about the complexity. And one way to start to get at that is to think about the number of types of traumatic experiences. And in our sample, our youth endorsed an average of 7 different types of traumatic experiences. And just a reminder, this is a sample of youth who are 18 to 24. So by the age of max 24, they had endorsed 7 of these experiences. Prior literature suggests that there are gender differences in rates of traumatic experiences, with males being more likely to experience some forms of trauma than females. And we saw this borne out in our data. These 6 experiences were more reported by the males in our sample than the females, while females were more likely to report experiencing sexual abuse. Rather than stopping at an examination of rates of prevalence, we wanted to gain a more nuanced understanding of what these youth are confronting. So using this data, we then did a latent class analysis, or LCA. LCA is a quantitative approach that identifies groups of individuals within a larger data set and allowed us to examine patterns of experiences across individuals. Our analysis identified 4 groups with distinct patterns of traumatic experiences, and what you see here are plots that show the likelihood that a member of a specific class would report a particular type of traumatic experience. This is that same plot from the last slide, but broken out into 3 panes based on category, or panels really, based on category of traumatic experience. Our 4 groups included a low interpersonal trauma group. So that's this group here in purple. This was our largest group. And then we had 2 poly-victim groups. These were youth who were very likely to endorse multiple different types of traumatic experience across our 3 categories. And then finally, we had what we called our high interpersonal trauma group. These participants were more likely to report interpersonal traumatic events, but less likely to report traumatic events across the other 3 types of trauma. So this graph offers a different way of looking at our LCA results. As you may recall from a few slides ago, we asked youth about 7 different types of interpersonal traumatic experiences. And as you can see here, our participants in polyvictim 1, on average, endorsed about 70% of those 7 different experiences, compared to our participants in polyvictim 2, who endorsed about 60%. Our 2 polyvictim groups were similar across the other categories of traumatic experiences. Then we have our high interpersonal group here, who endorsed a greater percentage of the interpersonal traumatic experiences compared to the low interpersonal group. But as you can see here, our low interpersonal group endorsed a greater percentage of experiences across the other 2 categories. So turning to gender and behavioral health symptomatology, you can see here that 35% of our female participants and 40% of our male participants were in the low interpersonal group, and they really fared the best across the Global Severity Index, somatization, depression, and anxiety subscales of the Brief Symptom Inventory, or BSI, which is a measure of psychological distress. In our polyvictim 1 group, we had 3% of our female participants, 20% of our male participants, and these youth really did the worst. They had the highest levels of marked symptom elevation across all indexes of the BSI. Then in our polyvictim 2 group, we had 37% of our females and 36% of our males. And in our high interpersonal group, we had 25% of our females and 5% of our male participants. And these 2 groups, kind of interestingly, looked similar across the BSI, with the exception of anxiety, where you can see here that our participants in polyvictim 2 had higher levels of anxiety. Turning to race and ethnicity, 44% of our participants who identified as Black or African American were in our low interpersonal group, and 50% were in our polyvictim 2 group. And then we have a little bit more of an equal distribution of our participants who are identifying as Hispanic, with 29% in low interpersonal, 20% in polyvictim 1, 13% in polyvictim 2, and then 18% in our high interpersonal group. So taken together, we can see that these young people who have experienced significant trauma that has substantial impact on their mental health are very much in need of treatment. So the next question is, are they getting to care? Frequently, the care needs of these youth have gone either unidentified or unaddressed in other systems such as school, and so linkage to care needs to happen in the legal or juvenile justice systems. We were able to start to understand treatment access for youth involved in the juvenile justice system with post-traumatic stress by using a different data set drawn from a study at the Center for Behavioral Health and Youth Justice that took place across 10 counties in New York State and used items from the Global Appraisal of Individual Needs, or GAIN. So here you can see over 26 months in 10 counties, we identified 112 non-crisis youth on probation. So we weren't too concerned about their risk for suicide, but they had unmet treatment need and past year post-traumatic stress. Among those youth, I should also mention that this need was identified at probation intake. So among these youth, 86% received a referral from their probation officer at the time of intake to behavioral health services. But only 66% initiated treatment. And when I say initiated treatment, I just mean that they attended one intake session. So we're not talking about completing a full course of CBT here. This means that 34%, and likely more, right, because we're just talking about an intake session, 34% of these youth had unmet treatment need. Also, in this study, we didn't ask about what type of treatment the youth were being referred to. So likely the treatment that they were referred to was not specifically tailored to address their post-traumatic stress. So overall, this indicates a need for adapted protocols to link probation youth with post-traumatic stress to appropriate care, and then additionally, programs to support their engagement with services. While we don't know why kids with post-traumatic stress in particular aren't getting to care, we do know that in general, there are barriers to care for youth on probation within systems, meaning both the probation and behavioral health systems, as well as youth and family levels, at the youth and family levels, sorry. Mandated screening and clear referral pathways can help address systems level barriers within probation, but we've seen in other work from the Center for Behavioral Health and Youth Justice that even when these barriers are removed, approximately 30% of youth still don't get the services they need. This points to the important role that family can play. As I mentioned earlier, the families of youth involved in the juvenile justice system can play a really important role. Indeed, family involvement is associated with improved service engagement for youth on probation, as well as better treatment outcomes for youth with post-traumatic stress. And family can also play a role in increasing other positive outcomes for youth long-term, such as reduced risk of recidivism and improved educational, relational, and health outcomes. Given this, the overall goal of my K23 research is to understand the specific barriers to care for youth with post-traumatic stress, and then build on existing protocols and programs to create an intervention called T-Connect to bridge them to trauma-focused care while increasing treatment uptake. Informed by findings from the first aim of my K23, which will identify barriers and facilitators to treatment for post-traumatic stress among youth on probation, attending to race, ethnicity, culture, and gender, as well as youth post-traumatic stress and prior experiences, I will tailor evidence-based referral and linkage protocols and augment them with a brief family-based psychoeducational intervention adapted from Target, which is a 12-session evidence-based present-focused trauma treatment for youth involved in the juvenile justice system. In addition to identifying youth on probation with post-traumatic stress and linking them to appropriate community-based care, the goal of the program will be to increase their and their caregivers' motivation and readiness for treatment while they wait for services to begin. In the last aim of my K, I will pilot test this intervention through a small RCT, examining feasibility, acceptability, and preliminary evidence of impact on treatment participation, as well as possible mediators and moderators of the effect. And with that, I would like to thank in particular my K23 mentors. I am lucky to have just a really exquisite team with Dr. Kate Elkington, Dr. Cristiane Duarte, Dr. Melanie Wall, Dr. Julian Ford, and Dr. Lisa Saldana. I would also like to thank the Center for Behavioral Health and Youth Justice team. It's really a privilege to work with you. And finally, I would like to thank NIH for funding my research, both through my K23, through a KL2, which I received but didn't have a chance to complete because my K23 got funded first. And finally, through a loan repayment program award, which I actually consulted with our very own Dr. Stephanie Rolin on, and she was very helpful. So thank you all very much.
Thank you so much. Well, last but not least, we have Dr. Bernadine Waller. Excuse me. Dr. Waller received her PhD from Adelphi University, completed her T32 fellowship here at Columbia under the mentorship of Dr. Milton Weinberg, and is now an assistant professor and K awardee in our department. She is the founder and principal investigator of the DIVA Lab and the director of community engagement for the Columbia Mental Wellness Equity Center, ENGAGE. Dr. Waller partners with faith and community-based organizations to tailor and implement sustainable evidence-based mental health interventions for underserved survivors of intimate partner violence, IPV. Her scholarship is guiding national domestic violence policies and protocol for the U.S. Department of Defense and Futures Without Violence. Her work has been published in Lancet Psychiatry, American Journal of Psychiatry, and the Journal of Interpersonal Violence. I'm envious. Her TED Talk, Hindered Help, illuminates the barriers that Black women encounter during the IPV health-seeking process and is part of the required curriculum at several universities. Lastly, I wanted to add personally that Bernadine and I are in the same division, and we share the same division administrator. And the division administrator said, Bernadine is like an antidepressant because whenever you talk to her, you just feel happier. So on that note, let's invite Dr. Waller.
Well, good morning. Thank you all so much for hanging in there with us. And thank you, Addie, for that wonderful and gracious introduction. I am super excited to share my work with you. So let's get it going. All right, so I have no conflicts of interest to disclose. And here are our learning objectives for today. And so I want to begin by underscoring that my research, my scholarship, focuses on intimate partner violence. Intimate partner violence is defined as any physical, sexual, or financial abuse, as well as psychological aggression, controlling behaviors, and stalking. The information is challenging, and for some, it could be triggering. So please note that self-care is so very important to me. So know that if you have to take a break at any point during my presentation, I really want to invite you to do so, knowing that while we have the opportunity and option to take a break, there are millions of people around the world who have no escape. So as the old adage goes, the personal is the professional. My work and my research really has been informed by women who I know, as well as my clinical experiences with this population. Seeing that Black women were really not fully supported as it relates to interventions, and then feeling helpless because I did not have the tools and the resources that they needed in order to get to a place of wholeness. And for those of you who were able to catch my NIMH presentation last year, I promise you, this is not a repeat, this is new information. And so the latest available surveillance data reflect that just over 53% of non-Hispanic Black women experience intimate partner violence. You will note that Black women do not reflect the highest lifetime prevalence. However, a 25-year inquiry notes that Black women are 3 times more likely to be murdered by their intimate partner than white women. In fact, they're not only mostly murdered by men that they know, they're also the most likely of women of any racial and ethnic group to be murdered by their intimate partner. So it sounds to me like we have a problem. Colleagues and I then examined all homicides and found that women racialized as Black reflect higher rates of murder. And as you can see in the pink, Black women are much higher than what you see in the blue, which is reflective of white women. We then found that Black women on average are 6 times that of white women. And in Wisconsin, you can see represented in the green, they're as much as 20 times more likely to be murdered than their white counterparts. So for every 1 white woman who's murdered, there are 20 Black women in the state of Wisconsin who are murdered. So as you can see, there really is an urgent need for us to center Black women throughout the continuum of intervention development. Now, I say this with the understanding that they are at the table. The problem is not lack of presence, but lack of power. We do a good job of including Black people at the table, but when they get there, do we see them? And when they speak, are we really listening? Based on the numbers and the data, it sounds like we're not doing a good job of either. Hence, my R36 dissertation award, the goal of that study was to develop a model that identifies US Black women's IPV help-seeking processes. I specifically aim to explain how Black women cognitively evaluate what services are available to them, and then identify how these women utilize their contextualized exercise of agency to navigate the barriers to their help seeking. I use theoretical sampling to understand women's experiences and pathways of support, specifically sampling women who were help seeking in the criminal legal, shelter, healthcare, mental health care systems. And since Black women are the most religious population in the US, I also sampled among women who were help seeking in their church and those who were looking for more private forms of help seeking, those who were seeking among their family and friends. I partnered with the Municipal Family Justice Center, which is co-located within the local family court, and used purposive and snowball sampling methods. The sample included 30 women, 83% of whom self-identified as African American. The mean age was 40 and had been in a relationship for just over 9 years. After experiencing barriers to their help seeking, most of the women stated, and I quote, "There is no help," and quote, "I have to fight to get out." So to protect participants' identities, I will be using pseudonyms throughout my entire presentation, but I just want to introduce you to them. 42-year-old Sharon lived 1 block away from the precinct, 1 block. She stayed on the phone with 911 for an entire hour, all the while her abusive partner banged on the door, through glass was crashing in the background, and she barricaded herself behind her bedroom door. And this is what she said to me. "We end up staying in this situation till we probably lose our lives because there is no help. Like for me, I don't know what to do anymore. I really don't know what to do. So I guess I'm probably just gonna have to stay until he kills me." Likewise, Tammy stated, "It's like you have to keep going over mad hurdles. I have to fight to get out." Yvette then stated, "You know what? I just go straight up the pipeline. They," meaning the providers, "didn't help me in the way that they should have. So I prayed about it." Prayer really does change things. Based on this data, I co-created 3 theories, which happen to be the first theories that help us to identify US Black women's IPV help seeking. The first theory that I co-created was the theory of help-seeking behavior. This theory postulates that survivors' social context, their beliefs, and their sense of individual agency actually inform which supports were really available to them. This theory is currently being used by providers in the New York City Mayor's office, as well as far away as Israel and the UK. The second theory I co-created was constructed agency. Constructed agency helps us understand why Black women experience the highest rates of mortality and morbidity. This framework is actually provided the groundwork for my first author publication. Some of you may have seen a couple of months ago in The Lancet, where we looked at and examined all homicides among women. I was super proud about that piece because they commissioned a commentary from the CDC and then spearheaded international news coverage, because that's how important this research is. The third theory I co-created was Sarah Waller's help-seeking model, which I just learned late last week, is being employed to help survivors in Spain. This theory was named in memory of my maternal grandmother, and of course I had to put my name in there, who is the epitome of a caretaker in her small rural town in North Carolina. As you can see, this theory identifies 9 nuanced phases of help seeking for Black women survivors, and it captures both their psychological as well as their social support needs. And the balance of today's talk, I'll talk about the work that I've done to extend the utility of this theory. So you see in the first phase is where survivors were largely experiencing internalizing disorders, specifically depression. I'm currently using this framework as an implementation science framework to guide intervention delivery for Black women survivors. And so if you want more on implementation science, I'm going to direct you to Dr. Natalie Moises' Grand Rounds from last year. Amazing talk, very engaging. And so for sake of time, check out her presentation. All right. So my next step was to conduct a systematic review of the literature to understand what Black women survivors need in evidence-based intervention. We found that they prefer assistance from faith or community-based resources. Intervention should be brief, that is 6 sessions or fewer. They should be provided by lay ministry or community leaders with lived experience with intimate partner violence. I then obtained a loan repayment, shout out to Stephanie, a loan repayment award and an OMH Policy Scholars Award to understand what elements anchor initial implementation and long-term sustainability of an evidence-based intervention in faith-based settings in New York City. I specifically sought to understand what are the barriers and facilitators, and then to identify what components of an evidence-based intervention that they wanted to be implemented in their settings. I utilized the integrated sustainability framework to identify key factors that influence pre-implementation sustainability. This framework allowed me to capture outer and organizational contextual factors, as well as intervention and implementer characteristics. Importantly, the integrated sustainability framework was being used to both develop the interview protocol as well as guide our analysis. I conducted in-depth individual interviews with 30 participants with maximum variation, including 10 Black women survivors of intimate partner violence with distal histories of IPV victimization, 10 providers who treat Black women survivors, and 10 women clergy. Now, the literature notes that clergy, not specifically the pastors, are willing to provide assistance and support, and not pastors. You can probably refer to Dr. Hankerson's work on that, but pastors are really busy. They're too busy to provide support that the survivors actually need in the churches. So when it comes to pre-implementation sustainability, we found that safety, both physical and psychological, were fundamental to ensuring that the intervention is successful. Autonomy is also key. Survivors want to have flexibility in format, personnel, as well as duration of delivery. There's also a critical need to make sure that their social determinants of health are also being provided, specifically providing childcare and making sure we're accounting for their transportation needs. I then sought to understand what are Black survivors' likelihood of accepting help. Unfortunately, not much had been done about that. Colleagues and I collected data from more than 2,400 people during the COVID-19 pandemic to understand what was the impact of the pandemic on IPV victimization and people's mental health correlates. We then conducted a latent class analysis to understand how IPV and mental health affects their willingness to accept help. Voila. I know you were like, does she realize this is a blank screen? I promise you, I realize that. So as you can see, there are 3 distinct classes of women based on their marital status, their religiosity, their levels of trauma, and stress exposure. And we found that regardless of these differences, that Black women, by and large, are willing to accept help if it's just offered to them. I then convened an intervention work group to begin formative work, completing initial steps of the adapted model for tailoring evidence-based interventions. 12 participants comprised an interdisciplinary team of providers, including psychiatrists, social workers, shelter managers, and attorneys, as well as a diverse group of Black women survivors, including African-American, African immigrant, Afro-Latina, and military veterans. They opted to tailor interpersonal counseling. For those of you who do not know, IPC was co-created by my division chief, Dr. Myrna Weissman. IPC is a brief evidence-based intervention for depression that can be delivered by lay health providers. They then decided which elements of this evidence-based intervention to tailor. They wanted to make sure that we're including psychoeducation and infusing tenets and principles of the Black church experience. Now, the Black church experience will likely be modular because not all Black women are religious, but Black women by and large are very spiritual. So that modular aspect allows us to be able to have greater utility. Ebony shared at the end of the intervention work group, this should be an all hands on deck initiative. And with the overwhelmingly and disproportionately high rates of mortality and morbidity for Black women IPV survivors, I couldn't agree more. And so I'm when I tell y'all super excited to share that my K-23 was funded T-minus 6 weeks ago. Yes, I'm super excited. Y'all supposed to clap. So the day I found that out, literally I was screaming around everywhere. So that's why I was expecting y'all to clap, because I'm still happy. All right. And so the first step is we're going to look the goal of that is to really look at refining our knowledge and look to see what impact the denominations of these Black churches have on Black churches really actually delivering depression screening and care. The next phase was then to utilize the adapted framework. And I chose adapted model because this is the one model for tailoring an intervention that centered the people that you're tailoring the intervention for. And I want to make sure Black women's voices are centered throughout the continuum of intervention development and implementation delivery. Finally, and I need to tell y'all, it's going to be called IPC Diva. I'm super excited about this name. Diva, right, is not just what you call a person who's missy and prissy. Diva, in this instance, is an acronym for divinely interrupting victimization and abuse. So I'm super excited about that one. Finally, I will be conducting a hybrid type 1 site randomized clinical trial to understand initial acceptability and feasibility of employing lay health providers to deliver this evidence-based intervention. And the lay health providers will not just be female clergy, they will also be lay leaders and community members. Finally, I want to thank my funders and my partners, specifically the NIMH, who has funded my work consistently for the last 6 years, along with the New York State Office of Mental Health. Special gratitude to my sea of mentors and collaborators, including Dr. Milton Weinberg, who's in the office, in the audience, Dr. Myrna Weissman, who I know is watching me and cheering me on, and Dr. Sydney Hankerson, who's also cheering me on. And to the survivors who trust me, there would be no me without them. And to get trust from a population that historically not trusting and traditionally known and is seen as being under-researched and hidden, for us to be able to collect the data from my last study in a record 3.5 weeks, that shows us just how excited they are that someone is actually centering them in intervention development. And finally, to my members of the Diva Lab, y'all totally rock. Thank you so much for being amazing. And I would like to close. Oh, sorry. That was sorry. Y'all ready for me to get off the stage? I know what it is. I'm almost done, I promise. I then would like to close by inviting you, if you'd like to have more information, to check out my TED Talk. I was fortunate to do a TEDx talk about 7 years ago now on my work with Black women survivors, and it's called Hindered Help. Thank you so much.